Good afternoon, ladies and gentlemen. It is now 4 o'clock, Monday, June 11, 2018. The Committee on Education, Finance, Taxation now convenes this public hearing. Public hearing notice were given to the media on Thursday, May 17 as the first. The second notice was on Thursday, June 7. And for the record, today is Monday, June 11, and the time now is 4 o'clock. The committee will hear and accept testimonies, both oral and written, on the following. Bill 264, as introduced by Senator Regine Kousouli, an act to add new section 26705 to Article 7 of the Chapter 26, Title 11, Guam Code annotated as added by the Public Law 34-87 relative to exempting basic need products from the general sales tax, and to cite this act as the Working Families Relief Act. Also, Bill 262-34 as corrected by prime sponsor, as introduced by Senator Michael F. Kousouli, an act to repeal Sections 1, 3, 4, 16, 17, and 18, and to amend Section 2, all of Public Law 34-87 relative to repealing the imposition of a general sales tax on Guam. Joining me for this public hearing is, we have Speaker Senator B.J. Cruz and Senator Mike Nicholas. The general rules for public hearing. The conduct of this public hearing shall be as follows. Those testifying will be recognized in the order of sign-up on the sign-in sheet. Written testimony may be read. Lengthy written testimony should be summarized to about 5 minutes. Written testimony shall be submitted to the committee. Please provide our legislative staff with your written testimony for photocopying. Testimony shall be confined to the substance. Persons will be allowed to present oral testimony only once. Once you are done, you may be asked to remain in the room for questions or for additional testimony, and may be desired by members of the panel. When you speak, please make sure that the microphone is on and that you speak into the microphone. Ladies and gentlemen, I did identify that the general rules is 5 minutes, but I do know that I was advised that there are a couple of the constituents would be exceeding the 5 minutes, which is not a problem because they'll be presenting a PowerPoint. So that being said, I would ask the following individuals. Okay. We'll have Mr. Lynn Sanghun to please come forward, and then we have Dr. Kousouli and Dr. Lanstrom. Is there anyone else in the audience that would like to speak? First Lady Joanne? Probably not. All right. Ladies and gentlemen, we also have signed up for Bill 264. Mr. Lynn Sanghun, are you going to speak in reference to Bill 264 or 262? Okay, you speak on both. Okay, you be the first one to speak, and then we'll have the other two doctors come forward. Okay? Sir, please just turn on the mic and please state your name.
Thank you, Mr. Chairman. My name is Mr. Sedfree Lynn Sanghun. Good afternoon, Senator San Nicolas, Speaker Cruz. Yes, I'm in support of Senator Regine Koussouli's bill for working families, because this is a very important bill, because this would help the working families that have 2 jobs, 3 jobs, just to survive. Maybe to some people, $5, $10 or $20 savings is nothing. But to the working family, especially in the private sector, this is big, because they are just living within their paycheck to paycheck. There's a saying that you'll never know the value of $1 until you lost all your money. 39 years ago, I finished my 4-year course, BS Chemistry, and my dad told me, since you're not continuing into medicine, why don't you just manage our business? I said yes, and within a year, I was bankrupt. I was addicted to gambling. I make it a career. I lost the $100,000 in just 6 months. So lucky my mother's sister became a doctor. And then I realized how important $1 is. How important is the money, especially for people that are living from paycheck to paycheck. That's why, in fact, I compare it to another bill of Regine Fiscal, to increase the registration of voters. As I have said, it could only improve 2% turnout. But, Mr. Chairman, if the Election Commission will continue to purge voters from the voter roll or remove voters because of failure to vote, then the bill is not really will be a big effect because they are purging like 10% of the voters, like 5,000, 4,000, and then the 2% turnout will only bring 2,000 votes, 2,000 new registration. That's why, yeah, there's a comparison. That's why I think it needs to be addressed. I request that the body conduct an oversight hearing against the Guam Election Commission on the purging of voters, because failure to vote should not be the reason to remove the voters from the voter roll. That's a law. And how do you know that they are not voting? It should not trigger a mail, sending mail to those people.
Mr. Lynn Sanghun, let's stick to the bill.
Yeah.
It's about the exemption, not the voting bill, okay? That will be discussed in a separate hearing. Sure.
Thank you, Mr. Chairman.
Okay.
Yeah, I just make a comparison because there's a similarity. That's why I hope the body will support Senator Lee's bill, because it would help the working families. Then those are the people that are working in the private sector, earning minimum wage per hour. Thank you so much, Mr. Chairman.
Will you be testifying in reference to Bill 262?
262.
Which is the repeal?
The repeal, yes.
Would you like to speak now?
Yeah,
so
yeah,
that
thank you.
You're the only one
Yeah, thank you
left
for
to
the
speak.
opportunity. You know. Yes, Mr. Chairman. By the way, good afternoon, Senator Nelson. I cannot blame the 8 senators that supported the increase of sales tax, because they have a point to. There is a crisis. Now, just like the Chinese saying, crises are composed of 2 things. The other one is opportunity. The other one is danger. Now we have identified there is a danger, and now we have identified the opportunities. Therefore, I believe that the 8 senators should reconsider, because there's a lot of areas that can support the general fund. And in fact, in case we still need that, and it's not enough, then we still have next year. It can be reintroduced again. But for the time being, I think it's a must to repeal the sales tax increase, Mr. Chairman, and especially that just the 2 main reasons is you want to help GMH, because 1% of the increase will be going to GMH and DOE. Now, regarding GMH situation, in order to succeed, they need to have sales. They need to collect money. They need to have good markup. And what's happening now with GMH, they have problem with the 2. They don't have problem with the sales. There's a lot of customer. Just from the 3M alone, it's already composed of 60% of their overall revenue. The Medicare, Medicaid, and the MIP. The problem is, on the Medicare side, the Medicare is paying GMH only $1,197 per gem for every day, for every Medicare patient. Now, but the Medicare is paying Guam Medical City, Regional City, $5,240. There's a big difference of $4,050. So how could you survive? How could you maintain your operation if there's a big difference? Especially that 60% comes from those 3M. Now, what is the reason of GMH? I have the report here by Mariana's Business Journal. And their reason is that, we need an act of Congress, first. And second, we need to follow up with them every day or see them. The Center for Medicare and our Center for Medicaid Services. The reason of the Medicare, Mr. Chairman, is that they are not receiving the data that they need. So to increase the per diem for Medicare. So it's like you're applying a loan to the bank. You want the loan? You need to give what they want. That's the priority. If you need to assign somebody in the mainland to follow up with Medicare or to see them every day, then do it. Because almost $80 million, that's the overall revenue from this 3M. And 40 million is from Medicare. Now, that's one of the problems. We need to solve that problem. If the legislature's resolution is needed to bring it to the Medicare services, then do it. Or you need to conduct an oversight hearing, ask them all the information or whatever you need in order to facilitate or to address this problem. Because that's one of the reasons why the cash flow is not there. They always need money. And then the second one, Mr. Chairman, the second one is the $15 million that you adopted from the fiscal year 2018 that should be coming from business privilege tax. That's one of the dedicated funding. They're always asking for dedicated funding. Now, that's one of the dedicated funding. The pharmaceutical fund, $15,772,163. My question is, are they receiving this allocated budget of $15 million that's coming from BPT? Or do they knew about this? Do they know about it? Then, Mr. Chairman, then the most important is the in-house audit. Ever since 8 years ago, the federal government and the Interior Department have emphasized, articulated, in order for us to increase the compact funding to Guam on the hospital or on everything, DOE and everything, is you need to provide us an in-house audit. Without in-house audit, we cannot increase the compact impact. Because you need to calculate all the contribution of the compact impact migrants. Because they are also working too. And that's what is missing, Mr. Chairman. That's why, we're only getting 1 to 6 million for the compact impact for the hospital. And then, right now, GMRC is getting all the business for the Medicaid, mostly of the Medicaid.
So Mr. Lynn Sanghun, you're in support of Bill 262?
I am support.
Okay, I just wanted to clarify that,
of course,
because next week there is an oversight with the Guam Memorial Hospital, and the information you have would be very important during that hearing.
Of course, okay. That's why I'm justifying it, Mr. Yes. Chairman. That's why I will leave this newspaper to you.
Please.
So you can have a record.
Yes.
And it's a report by Mariana's Business Journal.
Okay.
And that's the big money from the Medicare and the in-house audit that is required by the Interior Department. Because they need to see the contribution of these people from Compact Impact, because some of them are working too. Then we can justify that we need more funding. And Mr. Chairman, right now, just like what I said, in 2017, 40 million was paid by public health to GMRC for Medicaid and MIP, and only 31 million for GMH, meaning all the business now are going to GMRC. Now, why is that? Because they offer services that GMH don't offer, like cardiac and stroke. They have the intravenous services to help attack on stroke. That's the most important, because there's a lot of problem here with the heart attack and stroke. And most of the ambulance will ship them direct to JMRC because they have the equipment and the resources, the services that would help the patient, save the lives. See, and that's another 15 million difference now. You see, and again, the DOE. That's one of the reasons why you increase the tax to another 2%. You see, and I cannot blame you, because by that time you're not aware of the situation yet. Now, what can the DOE do? For how many years now? Maybe since I was a board member, we are already classified as a high-risk grantee, and we are paying $3 million to manage the federal fund. I believe that school have done a significant improvement. My reason is, why up to now we're still in the same category? Because we can save the $3 million and help it and use it for the school. So I think that needs to be addressed, and also need some forum or oversight hearing against the DOE. Why like that? And then the charter school. Yes, there's a law that we need to have 3 charter schools, but the point is, can we afford it for another charter school? We already have problem with these 2 charter schools. See, you can always repeal the law if you want to maintain the 2 charter schools and just stay with the 2 charter schools, or think it over if we still need it. And then again, on the DOE, they said they have $90 million deferred maintenance. So maybe it needs to be revisited. Just identify the priorities and what can we do to that we can repair it based on what we can afford. That's the bottom line, Mr. Chairman. Because public adequate education, only it's just the adequate alone is adequate, just what we can afford only. You know, and it's debatable, all those 14 points, because of the term adequate. Okay. And then, Mr. Chairman, yes, there's so many ways to improve the economy, to make sure that we'll never introduce another increase on next year. You know, just like fix the procurement law problem with all the departments, because that's the one that's slowing the economic activity. Imagine if the school is already ongoing, so money is flowing, it's revolving to the community, and as you can see, most of the appeals are from GPA and GSA, because the system that they're following is wrong. It's not in agreement with the procurement law. And then how many bidders are bidding? Only 1, sometimes 2, sometimes nothing. And then when there's no bidder, what they gonna do? Then they will order abroad. Then the money will go abroad. It will not go to the small business owner here in Guam. And then when they are very strict and not reasonable, Like, for example, in liquidated damage, even especially GPA, when you're late for 2 days delivery, they will penalize you. But when they're late in paying, they won't pay you interest. And then what this small business owner will do, next time they won't be there anymore. You know? And if you harm this small business owner, then you're not only hurting the small business owner, but also his workers and the whole community, because this money is revolving around the community. That's why it's important that they follow the law, that they become impartial and reasonable. Because there's, for GPA and GWA alone, there's like $1 billion money revolving on supplies and contracts, and then almost $500 million for other government agency. And if they're not following the law, then the money is only circulating to one favorite vendor or one favorite contractor. And then that affects the economy. And then another one is all the grants, Mr. Chairman, it needs to be disposed right away so that it will create economic activity. Because sometimes the grants are sleeping in their table.
Let's just take, I understand where you're coming from, Mr. Lynn Sanghun, but there's going to be other hearings that in reference to GMH, and I agree with you, there are a lot of issues we need to look at. But on Bill 262, it's about the repeal of the sales tax. And I understand that you're in support of the repeal, correct?
I'm support, Mr. Chairman, the bill of Senator San Nicolas.
Okay. And you're also
right
in
now
support of Senator
It's already
Lee's bill.
exposed all the areas that the government can collect money.
Yes.
And it's not a sign of weakness on part of the senators to rescind their vote and reconsider and vote now in favor of this bill.
All right.
Because just like what I said, there's always next year, if things will not turn out in favor of the economy, then you can always introduce it.
Okay.
Yes, and then one more last thing. Because to prevent these raises on tax and everything, also, Mr. Chairman, I believe the legislature should level the playing field in the political arena. Just like you're repealing this, but you introduce a bill that banned the political signs on public property. No, you're only condoning or favoring the people with the privilege, the people with political connection, and then with connection with the rich people along Marine Drive, where they can put their sign. How about those people that don't have money? Where they going to put their sign? That's very important, because equality and progress are two beacons that comes together. If there is equality, there is progress, Mr. Chairman. And then you don't have to introduce so many raises on tax and raises on everything.
Okay, thank you, Mr. Sang. Okay, thank you very much, sir. And we'll have now...
I will, give this.
Yes, but have it to my staff. They're at the table. We would have Dr. Kousouli, Doc, and Dr. Lanstrom. The baby. Dr. Lanstrom, if you can please come forward, sir. And if I'm correct, for the two doctors, you both have a PowerPoint, right? Okay, and we'll start with you, Dr. Kousouli. Okay. And before we begin, actually, I'd like to recognize my colleagues that have joined us. I have to my right, far right, would be Senator Talina Nelson, and to my left would be Senator Dennis Rodriguez. Thank you for joining us. When they're ready,
Is the PowerPoint
They're just
ready?
waiting for you.
Oh, is that it? I'm sorry.
Okay.
Good afternoon, ladies and gentlemen. I am ready to start my presentation. If you could bring up the PowerPoint. Thank you, sir. It is my honor, but also I consider this my duty to stand here and speak to you to convey my knowledge of GMH to yourselves and also to the public. First, let me introduce myself and explain my role at GMH. I know healthcare is complicated and hard to grasp, so I have created a PowerPoint, which you can see, so you may see my exact responsibilities and work I've done and accomplished at GMH. You can go to the next slide. As you may recall, I was hired by GMH in December 2016, just a little over a year ago. Upon hiring, my roles were as the Assistant Director of Medical Services, the Physician Compliance Officer, the Director of Medical Education, and the Director of PICU and Pediatrics. My role as an Assistant Administrator of Medical Services is probably the hardest to grasp, but it is basically involved working to improve every branch under my umbrella, which can be seen on the right side of the org chart. What you're seeing on the PowerPoint is the organizational chart, the most current one of the GMH. As you can see, the highlighted sections of this org chart is what I participated in, what I led, and then also continue to collaborate in a project with. I will not bore you with the details of what I did in each section and also the branches and under my umbrella, but since this is a fiscal responsibilities hearing, I would like to point out some of the things that I worked under my duty. On the right-hand side, as an Assistant Director of Medical Service, I oversaw some of the contracts for the physicians, not all of it. I noticed that the way GMH offered contracts had several discrepancies and disparities depending on each physician under contract. So I created a standard physician service agreement, which is fiscally responsible and fair to all. No special favors can be found in the new standardized contract. Under this new PSA, I executed fair, revenue capturing contracts to the anesthesia groups that we have at GMH, and also to the interventional radiologists and interventional and general cardiologists. Quality management was also a huge branch that I have led and took a leadership in. Utilization review is considered one of the cornerstones of the successful medical center. No hospital functions without one. It plays a crucial role in the hospital monitoring cost-effective utilization of resources. The UR team and the committee are key to reviewing hospital stays and denial, and it's so important that some hospital conducts UR meetings not only monthly, that's required by some regulatory agencies, but also have what's called UR huddle every morning to discuss issues. It's that important. When I arrived to GMH, I was astonished to find out that there wasn't a UR committee. All GMH policies regarding UR were old, last updated in 2009. I just want to clarify and want to go on the record. GMH has an excellent UR department, but they were working in silos without any support from administrations. Their brilliant suggestions and their recommendation are being unheard, resulting in GMH hemorrhaging cash. I have never seen a hospital that does not monitor an entire revenue management cycle, from hospitalization all the way to collection. No concurrent review is done during the admission, which I confirmed with the UR managers and also the members a few days ago. It's still not happening. And no reviews of denials were done collaboratively with the UR, billing and collection, and most importantly, with administration. Within 1 month of my arrival and starting at GMH, I resurrected the URC, Utilization Review Committee. Initially, because we didn't have enough members, I called it a task force. I have an email which I can submit it to you, dated December 28 of 2017. In this email, it captures my accurate assessment of GMH's fiscal situation, though I had just been there for a few weeks. You can go to the next slide. There you go. In it, I listed out 1, not having 2 midnight rules implemented despite CMS putting it into effect since October 2013. 2, GMH not having the list of most common denials and concrete solutions to decrease the denials. 3, denial of MFICU, which stands for maternal fetal ICU and all care. 4, social cases and with aberrant days. GMH never had accumulative days and revenue loss calculated for all of these social cases, which is a great lot, which have been leading great loss. And this is something that I urge that we must work with the legislatures and also with the governor together as a community. But without a data, how can we urge that? I focus on, even though I created those 4 points, I focused my first few months on implementing the 2 midnight rules at GMH, as this is the major source of revenue for any operating hospital in US. Every medical director and CEO in the US that I know prioritized this project when it first came out several years ago. I worked closely with Luis, the Euro manager, and Mr. Ed Byrne, together with billing, accounting, patient registration, and IT department. Throughout this effort, it is safe for me to say that, and it is truth, that I state that no administrator helped me nor supported us. They were silent. I also found out within the first few months that the most blood product transfusions were being denied by the private providers. I couldn't believe it. Private insurances are supposed to cover at least the minimum of Medicaid and Medicaid coverage. How could this be? Your manager, Luis, and Mr. Wally Santos pointed out, you're right, Dr. Kousouli, this shouldn't be happening. They educated me on Guam's laws, introduced by Senator Rodriguez, which specifically mandated blood transfusion coverage. Thank you, Guam legislature. You have been trying to help GMH since 2015. This law was passed in 2015. But despite the existence of this law, GMH was just swallowing and writing off these costs for years. I urged Mr. Ed Byrne to discuss this issue, and at first he didn't believe me. He said the same thing. No, that's not true. They are supposed to cover it. I showed him the report. We set up on a multiple meeting with the UR manager, myself, and Mr. Byrne, and he saw it for himself. So he followed up, thank God. I just confirmed with the UR managers and its members that starting January 2018, for the first time, we are finally starting to see no denials of blood transfusion. That means we are finally capturing that revenue. And my list goes on and on as an administrator, how much I worked in the VAS department as a director of medical services. It kept me busy, but that was not only thing. I was also officially appointed as a division chief of pro support on January 18, 2018 to lead those departments. You can look back to the organizational chart which is provided to you. It's all the way to the left side. You can see how many departments I led. I led all of it. This assignment was not given to me, nor discussed with me when I initially took the job at GMH. However, I accepted it gladly, and I'm so glad I did it. In after fact, I really liked working with them, and I really accepted it without any hesitation and without asking for any increase in salary despite the additional duty, because I knew the pro support managers needed representation to be successful. At this point, you can say that, and you can see it for yourself that I was working as the capacity of 2 full-time administrators. Even so, I did not fail my staff at Pro Support. Ask any of them. I was competent, available, supportive, and passionate for their success. Because I was working so closely in different departments, it was natural for me to start collaborate with the interdepartmental managers and its leaders. I collaborated with the fiscal team. I worked closely with Mr. Byrne. I found out that many departments in GMH worked in silos, so I created an interdepartmental task force to complete critical projects, such as I mentioned the 2 midnight rolls, implementation, and any more. You can go to the next slide. I keep forgetting about the PowerPoint, but I do have it. Prior. Could you go back? Thank you. This is an email that I sent out that, oh no, actually after, sorry, this is it, yeah. This is another email that I sent out that you can see I took a chairmanship in these interdepartmental meetings and projects. I'm assigning the MIS, which is the IT department at GMH. I'm talking to the UR team. I'm talking to the bedside nurses and also physicians, conducting the physicians' educations in regards to all these critical projects. You can go to the next slide. And this is to tell you, with that effort and in leading those projects, we are finally able to accomplish our first policy on 2 midnight rolls, April 2017. As I mentioned earlier, this has been introduced by CMS since 2013. Well over almost 5 years, we are finally able to bring this to GMH. I also collaborated, next slide. I also collaborated with medical records. Mr. Clement, I also collaborated with Mr. Clement to diminish the numbers of delinquent medical records. He was also desperate and sought my help while I was at GMH. He said that there were millions of dollars worth of delinquent medical records just sitting there. Physicians are not completing them, and therefore GMH cannot bill. You can go to the next slide. Oh, this is a blood transfusion cost generated. I'm sorry about my disorganizations because I do not have the copy of the PowerPoint, but this is to demonstrate about the blood transfusion, how many were given from between the month of January to April. As you can see how much this costs. Price per unit of PRBCs, packed blood cells, is $227. In addition, with shipping, staffing, administration of the unit, it's well over $1,000 that we are missing each unit that we administer at GMH. You can go to the next slide. This is the medical records. There you go. So where was I? Age charts equal lost revenue. Mr. Clement told me that he always has to speak to the delinquent physicians to request completions, but he was never supported by any administrators. He said that it was almost daily dread being yelled at, cursed at, and called names. Not only that, when he suspended these doctors, someone from high above just pardons their suspension and frees them from accountability. What I present you here in this PowerPoint is a snapshot, just a cross-sectional report given to me from the medical record with these delinquent charts amounting to, look at the bottom of the slide, $22 million at one point. Is that a lost revenue? Most definitely. It is a lost revenue that we could have captured. We worked together, Mr. Clem and I, to educate physicians of why finishing charts were so important. Most physicians were very supportive because they want GMH to do well. I literally went to almost every department and he thanked me, Mr. Clement thanked me for being the first medical director to do so and to stand by him. Despite my utmost effort to support him, this wonderful, competent manager, Mr. Clement, left GMH. He told me before he left, he cannot handle these multiple self-made crises with nothing being done about it by its leadership. He also told me and gave me a word of advice. I should also leave this island before I lose my say. I was devastated to lose my trusted right-hand colleague, and I dearly miss him. Budget is another thing that I closely worked with. Budgeting at GMH is very strange, and it's not based on actual numbers and a fact. For example, I saw Chef sitting there, so he can relate to this. Under my division, dietary, I started looking to dietary's budget. No one in that department actually knew how much any materials and food costed, because ordering of the food and some other things were done by another department. As a result, we could not estimate the revenue and loss at the cafeteria in the dietary department. What kind of restaurant function like that? You don't know how much purchases that you're making? How can you do that? So we worked hard, Chef and I, and also the members of the dietary. We found out that GMH was losing money every day we opened the cafeteria doors. So I worked closely with Chef, Mr. Byrne, and Carlos from the Fiscal department, and then we are trying right now to capture the revenue. It's happening, hopefully soon. Not only dietary, I also made sure I looked at the budget of each department under me closely to correct these elementary mistakes. In radiology, one of the huge triumphs was securing the budget to have our own quarters and biller in radiology. All of these efforts increased or will increase revenue for my division, my department, or pro support. My responsibility as an administrator kept me busy, but that's not all of what I did at GMH. I also placed myself on call as a physician. I made myself available 24/7 as a pediatric ICU doctor every day when I am on the island. I placed myself on call because I thought not only the kids on this island, but also to support my colleagues in the ER and also in pediatrics who needed it. We had some crazy cases that I remember, but I was so glad throughout those cases. I had those colleagues by my side, and I am certain they feel the same about me working in the front line together. For my clinical work, GMH never paid me to be on call, not even a single day that I've been here. I was never hired as a physician for GMH, nor was obligated to see a patient. At the time of the hire and multiple times thereafter, I asked, should I get a contract as pediatric ICU physician? They never engaged in that conversation. And multiple times, Dr. Lizama told me to just keep the professional fee. That's what everybody does anyway. I never knew of such practice, keeping the professional fee. I never even heard of it. I initially did it as he instructed me to do so, but realizing what it was, especially for poor parents and poor family, I started not to bill for my own, or in some cases, I billed it and I wrote down and then said clearly, billing directed to GMH. Sometimes family would send me a check for those professional fee because they were probably asked by those private insurance company. I voided the check and then returned it to the family with the notes. Because I know if you lost a child, they need it more than me. I kept working as a PICU doc regardless without the contract because I love my job. Let's simply put it that way. It is a joy the money cannot ever buy, partaking in the miracles of lives. The dying child takes a breath, and I get to return those kids to their mother's hands. Not only those works as doctors, I also volunteered. I volunteered to teach nursing students and pre-med students at UOG and GCC whenever they were at my department. I encouraged them. I also participated in the EMS meetings and gave lectures whenever the EMS and public health asked me to, because I believe that interagency collaboration is the key to success in raising the standard of care here on Guam. I also collaborated with the philanthropy volunteer groups like Make-A-Wish Foundations and GMH VA Pink Ladies. I work closely with these organizations so that I can ensure the kids can be granted with that special wish or have the special equipment that they need. As you can see, I was vastly invested in the operation of GMH and the island of Guam, not only as a physician or an administrator, but also as a human being. However, despite taking these crucial roles contributing to the progress of GMH and serving the community, I was quickly alienated by the executives within few months of me starting at GMH. As I became more and more vocal about expressing my difference in my opinions over their inefficient way of running the hospital, the tension and the hostility became tangible. I hated going to work because of it every day, because I knew the hostile environment waited for me, and I never hated going to my work, ever. I was intentionally kept out of the loop, and a few times I experienced them physically shut the door on my face. In my naive state, though, I tried to engage the CEO and the CFO about my findings over and over again, in meetings and directly in person. Despite my effort, they have continued to dismiss me. It was so discouraging, and I had never been treated in such disrespectful way in my adulthood. But I endured it because I hoped I could make a difference, still make the difference, working behind the scenes. However, despite my best effort, the real clash between the rest of the executives were inevitable, as GMA's administrators and I stood on different principles and different ground. Let me list out those recent clashes that I remember so clearly, and I would like you to know, and I want the public to know. First, Joint Commission reports and talking points. When GMH was reported losing accreditation from Joint Commission, they put forth a narrative that this was due to funding issues. Remember that? This was right here. I made my concern very clear to each one of them. Sitting behind me, this was not the full story. The majority of joint citation was clearly due to leadership issues, and we were not going to be able to hide it. The public deserves to know that. The key to winning trust of the public and of you guys is for us leaders to take ownership of our failures, and this was the course of action I urged multiple times. Not only did they not listen, but they asked me not to come to the working session called by the legislature or to any hearings despite me being the physician compliance officer. Many times I discovered that there was an oversight hearing conducted by Senator Rodriguez about Joint Commission after the fact. When I asked why I wasn't invited, Benita told me that the legislature wanted a small group, so Dr. Lizama and Dr. Duenas was there via text. When I asked the same question to the CEO, he said the same thing. The Senator B.J. Cruz and Senator Rodriguez only wanted those doctors, not me, because I was new and didn't understand things. Later, I found out there were no such requests from neither of those senators. They lied to keep me away, because I told them multiple times, if you guys ask me that questions about Joint Commission, I said I would say what I just said. It is a failure of leadership. When the Joint Commission report became public, they kept asking me and my staff to show up at the press conference to help make their case. We were given a piece of paper which had all of the talking points, and I think I have that in the PowerPoint. Could you please show that? There you go, talking points. On it, These talking points. On it, to make sure we say the Joint Commission accreditation loss was due to the funding, I received a direct phone call from the CEO saying that I have to bring all my managers to support this and who are in my division. I called the division meeting emergently and discussed it with my managers, who reported the feeling of being uncomfortable at the being put in this position, and then they didn't believe in that narrative. So I made the decision as a chief to relieve them of the requirement to come to these press conferences so as to not to coerce them into speaking points that they weren't 100% on board with. I called both medical director and CEO that day, asking them to reconsider this approach. As a Joint Commission failure was a leadership failure, and that we must take ownership of it. Later, I was informed by the staff at GMH that GMH admin completely denied that they gave out those talking points. But you see it there. I received it from their hands. Since this incident, they increased their effort to alienate me and dismiss me from any crucial conversations. They had a WhatsApp group called Modernization Chat or GMH Strategies, and I was excluded from all of it. They kept much of their agenda secret from me, but I continued to speak out if I found out their acts to be unethical or irresponsible. Second huge clash. Disagreement about the finance management was huge. Most recent was happened on February 9th. Another disagreement surfaced, this time at the Board of Trustees subcommittee at the Finance and Audit subcommittees. The CEO and the CMO were suggesting more spending to pay doctors to keep them in participating in the committee and meetings. I thought it was ludicrous to pay physicians up to $150 per hour just to show up to a meeting and committees, which they are required to participate in based on their new contracts. While on the other hand, we can't even give an appropriate raise to the nurses and my professional support teams. Especially since I already identified a group of willing physicians and CRNAs who are taking leadership and volunteering to attend and chair these committees for free. I also informed them in this meeting that in the interest of transparency, it wasn't an appropriate thing to bring this discussion up to the board level without an initial discussion with other leadership, such as the CNO or myself. A better venue, such as Executive Management Consult, where all of us attend. Why was this not brought up to us before we hit the board? You can go to the next slide. I have that. That's the memo they try to present at the board. With this estimate, by the way, for $150 to 150 hours per hour times 10 hours, you would be paying up to $78,000 to each physician to attend a mandatory meetings that he and she is supposed to attend. This made no sense. Third clash that I had. You can go to the next slide. Next slide, please. This was, I debated actually, should I bring this up or not, but I'm going to. Another incident I thought it was very unethical emerged. Regarding this political ad posted on February 11 as "We Love GMH" campaign. On this morning, the photo was taken. I noticed that many of the RM managers and some physicians were asked to go to the Z-Wing. Everyone was given different information about why this photo was being taken. Then I saw the governor's media crew show up at GMH. I thought some things doesn't add up, so I excused myself from being in the photo and asked the CNO and her deputy if they knew what was going on. They were just told to bring staff to Z-Wing, so they asked the staff to report. Later, we all discovered that this photo was taken for political ad titled "Senator, Do Your Job" with "We Love GMH" logo for Tenorio campaign. I called the CMO and the CEO on this immediately and told them this is not okay to use the staff for political campaign without their consent. They even had, go back to the picture if you could. They even had UOG students and the GMH volunteer association staff who were not supposed to take part in such political activities. When asked about it, they had no idea. When I asked admins these questions, their only response to me was simple. Oh, they all knew. And they didn't further engage me in this conversation. The last one that I'm going to mention to you in the huge crash that I had is a Payless Friday threat, as I call it. On March 9th, the CFO and the CEO abruptly announced there was not enough funding to cover payroll. Do you remember that? That was all over the news. We had a Board of Trustee Fiscal meeting just a few days prior, but during this meeting, there was no mentioning of any issues with shortage of cash severe enough to stop paychecks from going out. They didn't tell the board. The announcement of Payless Friday was done via the chat. You can go to the next slide. And email memo by the CEO and the CFO. As you can see, which I thought it was absolutely unprofessional and cruel. It started out with a strange text from Benita at 7 in the morning. I can't read it. It says, despite the constant threat of Payless Payday, the community is blessed with a group of hardworking, dedicated GMH employees who continue to do their best in providing the best of care. 7 o'clock. We had no idea what she was talking about. What's going on? Oh, thank you, sir. This would help me greatly. So, the chaos starts. Here, I started, and then by 10 o'clock, we all knew that all these paycheck was being held. I started to get a frantic panic phone calls from my staff, some crying because they were worried about not being able to purchase food and pay mortgages. You know what I did then? I immediately called the DOA, Department of Administration, to assess the situation. The staff at the DOA told me that there were enough funds to pay for all of GMH employees that day, but it was the decision of CFO and CEO not to do so. They couldn't tell me anything more. I then immediately called to express my concern to the CMO, as it appeared again that they were using GMH staff as political pawns. I reminded them this is illegal to hold pay from employees like this. The checks were released at 4:47 p.m., conveniently, right before the end of the day. And this fiasco ended. Can you go to the next slide? With the perfect ending. Look at that. To the right. 5:24 p.m. After the paycheck was held, after this fiasco ended with this text, Benita, 5:24, please reach out to the senators. We need help. This has been a minute-by-minute exercise of whether we are going to meet payroll. It has been an ongoing dilemma, but we will continue to fight for GMH. Please help with that effort. So right after the payroll fiasco ended, the first thing you do is call the senators. Speechless, I'm sorry. Later, not only that, later after this was done, this fiasco was done, few of the staff members who does not wish to be identified disclosed to me that the checks were already there to be delivered since that morning. One of the staff members even overheard Benita saying, I don't know if I'm going to release the check, we'll see, very nonchalantly. These two staff members who had come to me independently without knowledge of the other were very upset how the GMH employees and the people of Guam was being used as pawns. Fire stations and police stations were being closed to get what they want. You know, what was concerning the most was the apathy of the staff. They didn't panic. They knew this was just a political theater, and they just endured it, like a child who is used to being abused. They need to know this. It is not normal to be treated like this at workplace, and they are now accepting this as a part of their lives. They deserve better than this. They deserve a leader who stands for them and says it is not okay to play with their lives like that. I could go and on about how stupid I was, and I couldn't keep my mouth shut every time these unethical incidents surfaced. I didn't keep my mouth shut because, I got to know these guys who works with me, the members of ProSupport, nursing staff, GMH members who are wonderful, and they became my friends and my colleagues. How can I keep silent? As a result of me speaking up, it was inevitable for me to be retaliated. I could not avoid their ultimate retaliation, one dispensed to others before me who have also spoken out. I had become an insufferable existence to a GMH administrator. On April 13, 2018, they abruptly served me with a notice of relieving me of all administration responsibilities. There you go. That's the memo. In this memo, they said the reason for my abrupt removal from my position was because to fill a critical shortage of pediatric hospitalists. This is entirely fabricated, as the call schedule demonstrates, which I can submit it to you, by the way, for the entire month of April and through the June is covered. There is no lack of coverage. In addition, pediatric unit census was so low in April, there were several days without any admission and was even closed the unit on some days. There was no situation so critical the Department of Pediatrics couldn't handle it on its own. Furthermore, I already knew the pediatric hospital was kind of going to be in shortage because one of the members hospitalists was going to be on the leave for medical reasons. Being who I am, I was willing to help for free, and I offered it for free for a few days and offered to cover the shift. Most pediatric hospitalists at GMH runs for a few hours in the morning, and then they leave the hospital to go to their clinic. They have a second job or third job. Why couldn't I do the same? Work for a few hours and run for them, and come back and do my administrator job? Why couldn't I do that? On this April 13th meeting, Dr. Duenas, the CMO, continued to insist this was the administration's decision and they can do whatever they want. On the record. And they didn't want me to work few hours and go back to administrative duties as all the rest of the medical directors were doing. Just to explain, not only the hospitalists, all the medical directors at GMH, Dr. Duenas and Dr. Lizama, comes in for a few minutes or a few random hours in the day, during the day, and they go back to their private clinics. So what makes it so different from me working as a hospitalist and then help out and do my duties? In this April 13th meeting, I asked if there were any issues with my performance as administrator. And he repeatedly told me that I have done an excellent and tremendous job as an administrator. I asked Dr. Duenas straight up if this was due to my difference in opinions politically and the way I have been very vocal about the difference in my opinions politically. and this administrator handled many situations. I thought it was so inefficient. I was vocal about it. Dr. Duena stated, it could possibly be, but I don't see it that way. I refused to accept this memo and their request to move me to the clinical side. As you recall, I told you earlier, I was never hired at GMH as a physician. I never had a contract as a physician. I was volunteering as a physician to see patients. They cannot force me to move me to work for them as a physician prior to me as a physician agreeing to it. I told them straight up again, this sounds like demotion and smells like retaliation for speaking out. I asked for a meeting with the CEO, but they did not even honor my request. Such a simple request. Until this day, CEO Peter John Camacho has never reached out to me to speak with me. If this really was about critical need to cover pediatricians, and one of your executives, your colleague, felt this was a retaliation, and she's feeling that she's retaliated against, as a leader of an organization, wouldn't you try to reach out and explain otherwise? This is a misunderstanding. The fact that CEO did nothing and remained silent, it confirmed my doubt. This had nothing to do with the critical need for pediatric hospital coverage. Despite my refusal, they immediately removed me come Monday. This was a Friday the 13th. Come Monday, I was gone, just like that. My staff was directed not to speak with me or report to me, only to report to Dr. Duenas. And I have a multiple texts and confirmation from the Department of Chair stating that there is absolutely no reason for me to cover pediatric coverage. As if that was not bad enough, come May 2nd, they came here, lied about me under oath. This is what brought me here. I was gonna go quietly, just like others did. I have a job offer in California, it's nice. I can leave no problem. But what happened? Here on May 2nd, I considered an atrocious act. Right in this very room. Not only was wrongdoing done behind the scenes in secrecy, I found out that once again they lied under oath, just like they did about Joint Commission, misleading the public on purpose once again. On May 2nd, multiple of my staff called me and said, "Doc, quickly watch the live feed," and I found out what was going on. They were being specifically asked questions specifically related to my removal from the office. I think it was Senator Sanekos who asked that. Then the CEO stated, "It was a personal matter I cannot speak to." I quote, "I can assure you this had nothing to do with my personal matter. I still wanted to continue to serve and be effective in this organization, and my staff made the express wish known to them." This line administrators of GMH even stated that the division chief of pro support position had been vacant for years. And again, I quote, and quote, "No one was operating in full-time capacity as their chief." You can go to the next slide. Oh, that was my memo. You can go to the next slide. Next slide. Even though I have the memo here that you can see appointing me as a full-time capacity as a chief of division of pro support, the job description of division of pro support was placed in my HR file by the same person who just lied and said there was nobody who was working in that full-time capacity. HR manager confirmed prior to me coming here. The only reason why the organizational that I gave it to you states vacant as it is simply because GMH's mistake. Quote, she said, they should have done that. Your job description is in your personal jacket. Not only this, on May 2nd hearing, GMH administrators appeared visibly shaken up by those unexpected questions, but they continued to mislead the senators and the public. When Senator Teralhi asked about, so who is the Assistant Administrator of Medical Services? Dr. Duenas said, Dr. Kousouli. I quote, as if I still had that position. However, what they did not disclose to Senator Teralhi and the rest of the members and the public was on that very same morning, Dr. Duenas and I had the follow-up meeting. In the follow-up meeting, I pointed out that evidence, I just showed it to you, there was no critical need for pediatrics. It was fabricated, as I just described. Dr. Duenas continued to say, you are removed from all administrative duty, no matter what. And that I had to move past it. He told me clearly multiple times in that meeting, which again, I can submit it to you as an evidence, that I am not to do any administrative duties whatsoever. Dr. Duenas said, your managers have moved on. You're gone. This is an order for you to move. I told him, you cannot unilaterally decide this. I'm a human being. So now one should ask, why didn't he say that? Be honest. Say honestly to the public when asked by Senator Teralhi that who held that position of Assistant Administrator of Medical Services. Why didn't he say it? It's vacant now. As he had just removed me from the position a few hours ago. Because they absolutely wanted to hide the truth. They hide the truth from everyone. They hide the truth from the BOT, Board of Trustees, from senators and the public. And I can confirm to you, my removal of the position was never discussed at the Board of Trustees meeting at HR. Several of the board members didn't even know about it. Transparency does not exist at GMH. Neither does accountability. I'm wrapping up, but I want to finish it up with this, because many have told me to just walk away. Don't come here, it's stupid. That the people at the GMH who runs it will always be corrupt and dishonest, and no matter how much I try, I won't make a dent, I won't make a change. One board member even told me that you're getting too close to the truth. There is a talk of getting rid of you. Be careful. This is back in February. It is not worth your time. Just go along with it. But I couldn't just walk away. The decision to do this right now frightened me, to say the least. I cried and I was shaken up. I have seen with my own eyes and heard what had happened to those who spoke out. Allegation of sexual abuse, drug abuse, and other false allegations were leveled at those who spoke out. Some physicians' lives were forever ruined because they spoke out. I've heard all of this. And I'm already starting to hear about some false allegations they are making up about me because I too spoke too much. To give you a tangible example, 2 days ago, prior to this meeting, on June 9th, I received a text from a trusted colleague I respect so much. This colleague said, I got a strange phone call the other day. We proceeded to speak over the phone. This colleague received a phone call from Benita Manglona, who has not spoken to this colleague in months. The colleague then disclosed Benito started saying to me, "Do you know Jose is stabbing you in the back? She is contacting the board members and the senators saying that you are overpaid. You should be paid about 300,000, less than half of what you make. I'm telling you, she's throwing you under the bus and she's lying about it." When the colleague asked her when this backstabbing occurred, Benito said, "Oh, back in February." The colleague questions Benito then that, "I don't see any gain that Jose has by stabbing me, and why are you telling me this now? It's June." Benito didn't answer this directly and asked what the colleague thought about me. The colleague stated, "I respect her as an administrator and clinician." Benita then said, "Well, I'm gonna go fight for GMH on the way to legislature." They hung up, then she hung up the phone. Fight for GMH. The colleague and I discussed this incident at length and rightfully identified that this was high school level manipulation and a game that she is trying to put us against each other. I'm appreciative of this honest colleague who had enough courtesy to call me, but this is exactly what they do. A whisper campaign, as someone correctly described. If Benita is calling this my colleague, who else did she reach out to? What is her motivation except to undermine my credibility and integrity, then alienate me from my colleagues? This is character assassination at its best. Try to assassinate my character. Try to ruin my reputation. Try it, because I will stand here still. Because even though they disrespect me and they play this high school level game, I'm still going to be here and speak out. Because the reason for me being here on this island and my message will never change despite these atrocious threats. I believe that the well-being of GMH directly connected to the well-being of my patients, the children. That children, they surely deserve to have a PICU doctor on this island. But these corrupt, self-serving administrators decided to protect themselves instead of the children. You know what it means for me to leave this island? It directly results in more death of the children. This is a fact. They chose politics over the death of their own children. That children surely deserve someone who can be their voice. I made a commitment to become the voice of the voiceless. Then I must do my utmost best to correct the course. In Guys and the Crime Mother, I asked him to come multiple times. Come see in pediatric department what I do and what we do over there. They cry and say, "Take me instead," those mothers. When a child dies under my care, I cry every time. Still to say, it's a traumatic experience even though I'm just a doctor. I feel like a little piece of my soul dies with a child every time. But instead of this traumatic experience letting my soul being chipped away and become a careless and say, "This is just Guam, just give up," I renew my commitment each time to make healthcare better here so less kids die here. After I've seen those cries, how can I be the only person to be safe and keep silent? I just couldn't. The truth about GMH must come forward. Yeah, it's true right now. GMH is in a bad situation. We're gonna need help from you, and I trust that you will help us somehow. But another truth that I discovered, we are not doing good because the executives of GMH is not being the good steward of its money. allocated from its citizens. We could make so much progress if we ended few old practices and inefficiencies at GMH. This lack of responsibilities that GMH administrators have, this must absolutely stop. They have to be absolutely transparent in allocation of its publicly funded budget, so there is no room for waste or corruption. They cannot, at this point, without doing their best, ask another burden from this public, increasing 2% tax from a poor community. How can they do that? How can they ask these people to shoulder this burden without doing their due diligence? It is unethical. And this clear retaliation towards an administrator like me who was moving with the speed of lightning, borrowing the words of my staff, they removed me just like that. This clear retaliation demands absolute truth as a response. My loyalty will always stand with my patients, the children. I don't care what they do to me, how many stupid decisions they make, but I care that they die because of their stupid decisions. They need to be held accountable for that reason. I have option to walk away and relocate to California anytime I want, but the children don't, and the people of Guam doesn't have that option. This must stop. This irresponsibleness, retaliation, all of this must stop. It has to end today. And I sure hope that you guys do your job as senators, that I am the last person to be retaliated for knowing the truth and speaking out in this organization. I want to conclude my testimony, and I just want to thank you guys. And I want to thank her, my daughter, for coming here. Thank you. She's beautiful, isn't she? I feel like I'm ruining her childhood by coming to legislature all the time. This is not her first time coming here. But you know, the real reason I do it is because of the next generation, because of my daughter. It's hard to talk about this. It's hard to have this ruin your career and future. But I do it for her. Because if I don't speak out today, it's the next generation who suffers. It's my daughter that I teach, and I say, when you see somebody being bullied, you speak out. You take a bullet for that person. GMH employees are being bullied, guys. I'm taking a bullet for them. I will do it because that's what I teach her. I teach her to be honest. Don't steal from people. I'm going to live that so that she can see me today, and maybe when she's 40 years old, she'll remember it. I don't care what they say about me. I don't care how many things they do to ruin my reputation. They are already working something up. You will hear it. Something about me. Something negative will come in public. Maybe that will ruin me, but I don't care. Because you know what? I care what she thinks about me. I want to do it for her and the children of Guam. This is the end of my testimony. Thank you.
Thank you, Dr. Kousouli. Dr. Lanstrom, you have also a PowerPoint, correct?
That's correct, sir.
All right, sir. You may begin your testimony.
Thank you, Senators, for allowing us this opportunity. I notice this is a gorgeous building in here. I look around, and I'd like to see GMH look like this, but it doesn't. I've been here working at GMH since 1990. I'm supposed to have my PowerPoint on now, please. So I don't mean to offend our current hospital administrator, Peter John Camacho, who's sitting behind me. He fills a very difficult position. It's a systems problem. It's an institutional systems problem. So whoever you put in there, into these positions, things don't happen. They stay the same. So I like to discuss this as the hospital is our only public hospital on this island. Anybody can go there. However, there is behind it a shadow agenda and an obscured finances and shadow politics. I speak as a board-certified surgeon and hand surgeon, a veteran of foreign wars. I am a veteran of Operation Enduring Freedom, Combat Zone, so I'm not worried about what is going to happen to me from testimony. If you've been in a combat zone, this is negligible. Next one, please. What is holding back our only public hospital from fiscal responsibility and that has impaired and may impair the quality of care? Is it dollars that you see up there? All those dollars we're pouring into a can that has holes, and you keep pouring water in there, and it keeps on coming out, and you pour more water in there, but you still don't get that can filled up. Is it management or is it politics? Next slide. So, GMH has been exempted from the legislation and laws by this body in the past. It allows the hospital to decide what contracts to issue and without any oversight by this government. If you read your Guam Code annotated, which I've put up there, it's kind of small, you can see that the law states that GMH must decide how to deal with obtaining service contracts, equipment, and supplies, and are exempt from the Government of Guam Act for procurement. This creates some problems. So this is a political cause. The hospital is required through their board of trustees to determine what type of contracts and how they're going to issue them. Next slide. Do you have a copy of this? Because I have a hard time seeing that. Can somebody bring me a copy of this presentation, please? So there's 3 points here I want to make that you can see these arrows. They point to the center. And the center is the taxpayers of Guam. Ouch. Next slide, please. And this just basically reiterates what I just said. GMH is exempted from Guam contract law. This body exempted them. Next slide. Next slide. And and the board of trustees, which you know we didn't have for a while, and that board of trustees was populated by appointed by the Governor Calvo. And I've seen the Board of Trustees be one person, also the same person as administrator. That's a conflict of interest. If you read the policy number, next slide, the policy number that GMH promulgated in October 2016, approved by the Board of Trustees, you'll see that They will abide by service contracts and other material supplies through the government procurement law, but not physician service contracts. This is a fertile tool for political favors, nepotism, greater expense for the taxpayers of Guam, and has and can be a foundation to erode the quality of care. Next slide. So I asked the senators and the public and the hospital and Peter John, why are there potentials for eroding the quality of care? Answers. Physicians that are employed by GMH can be terminated immediately without cause for no reason except for, I don't like you speaking out to a newspaper. I don't like you going to the legislature. Why? They're unclassified. They are fearful of losing their job. They're scared to say something. So, here you got an institution that this is well ingrained into, so it kind of allows a certain group of physicians to populate this hospital and kind of like what the doctor said here, kind of turn a blind eye and just be quiet and do your job and keep getting paid. And therefore, you can impair the standard of care. Believe me, I've spoken up before and I was raked over the coals, but I was completely exonerated from that. In fact, they even reported me to the Inspector General of the Navy because of my complaint about the standard of care. It went all the way up to Carl Levin of the military committee when he was in the majority as a Democrat. And it went all the way up there. And they came back and said, nope, he didn't do anything wrong. This is a bunch of bull. GMH physicians are, as I said, unclassified employees. Next slide, please. All GMH physician service contracts are granted and terminated by a single individual. I thought we lived in a democracy. I thought we had some oversight or thing. Thank God we live in a democracy. I would certainly not want to live in North Korea with Kim Jong-un deciding what to do with me. So why is this a problem for GMH? Next slide. Because, one, there is no requirement in Guam law to procure the best quality care for the best price through competitive bidding for the Guam taxpayer. The hospital just goes, give us more money. Did they bid out the contract for the current contracts for any physician service? Have you seen the physician service contracts? Voila, Mr. Manajan, none. Next slide, please. Wait a minute, you already went there. Next slide, okay. Number two, instead, physician contracts are granted for political favoritism, nepotism, without financial oversight or necessity or patient care. Chinchilli politics. Oh yeah, my party here needs a job, and we got the right governor sitting in Adelup right now. And that's not just this administration, but it's every administration. Next slide. Number three, selecting a physician to occupy a GMH service contract a physician that's occupied will not dare risk loss of employment, except for my doctor sitting to the left of me here, due to inability to be employed outside of Guam or for the same salary. Some doctors practice on Guam because they can't practice in the States. They found a little niche here, so they'll do whatever the administration wants. hey, you write this person even though it doesn't deserve it, or you say this about this doctor because he's talking too much, and we don't want to be embarrassed. And next thing you know, that person does the dirty work for the administration. Next slide. Selecting physicians to occupy a GMH service contract that will not dare risk losing or by pointing out patient safety quality. Because you're in that position, most of the physicians will not stand up, will not state that there's a quality of care or a patient safety issue. They fear to lose their job because of their status. You got one person that holds the gold, and he who holds the gold makes the rules. Next slide. No, back to 4, you went too fast. Oh yeah, okay, you're right. Go back to 5, please. So why is this? Well, all of us have bias. It's just our nature. And sometimes that bias can turn into revenge. And I have specific experience with that. I, at one point, was the chairman of the Board of Medical Examiners. But unfortunately, very difficult task. 2 physicians were convicted of federal narcotic felonies. The board had no choice to suspend those physicians. In the States, they'd have lost their license for years. Okay, I was a chairman of the board. The AG's office was with us, and we had no choice. I signed off on that. And because I signed off on that, I have had nothing personally good come from it, obviously. It has put me in a bad light of any activity since then. But it was the right thing to do, and it followed the rules, regulations, and the law passed by this body. And it's my humble opinion that the current medical director at GMH has a bias because of this. And because of this bias, he won't even entertain allowing a combat veteran that came back from Afghanistan with no job to work as a board-certified hand surgeon at GMH to provide care to this island. Instead, what do? They take a general surgeon / hand surgeon, employ that one person full-time at a very high salary. And I can tell you, I've been taking call at that GMH hospital since 1990 for no pay, working as a hand surgeon and a trauma surgeon and a surgeon doing neurosurgery, head traumas, and everything else under the book to save life and limb. And not 1 cent was paid for that. There was no such thing as house call physicians. There was no such thing as a house surgeon. You just did your job. Not to say that the system is bad now. It's good. It needs to be done because of the impact of taking care of indigent patients, and you're trying to make a living yourself. What I'm saying is that currently and in the past, I am certain that the hospital is bleeding money from having a full-time hand surgeon there. This population is not large enough. The type of insurance that is present would not support, in my opinion, that salary being paid right now. Would it support a part-time hand surgeon? Yes. Would it support a surgeon that was doing general surgery and hand surgery? Perhaps. But have you looked at, before pouring money into that institution, have you looked? Has there been an audit? No, there hasn't. Not since 2015. Next slide, please. Next slide. GMH, there's a graveyard full of fired physicians that have been terminated for speaking out and being stewards of quality of care and patient safety at our hospital. They're not here anymore. They're gone. They were high-quality physicians. They saved a lot of lives. These physicians typically leave island, and this adversely affects the quality of care on this island. Keep that in mind. Next slide, please. Sadly, again I say sadly, this GMH administrative standard operating procedure is still going on ever since I first stepped on this island as a Navy surgeon. And as I make this presentation today, it is imperative to retain high quality physicians at GMH service and the people of Guam, including the doctor sitting to my left. Next slide, please. Who is the individual that can hire or fire a physician at GMH? Does anybody know that? The gentleman sitting behind me, Peter John Camacho, and the medical director. If there wasn't a medical director or an administrator, as you know in the past, the previous governors of Guam have taken over that role, and then they can hire whoever they want to fill these positions. It is the governor of Guam directly, or through his or hers appointed hospital administrative proxies. Next. So you see, it's a systems problem. Whoever fills that systems problem, they're stuck in it too. So it's not to isolate one individual. They all try their hardest for the best possible outcome. To aggravate this arrangement, GMH is only required by law to advertise for physicians' service contracts off island. Did you know that? And it's in their administrative bylaws. So if they want to find a doctor, a pediatrician, pediatric intensive care unit doctor, as my doctor to my left here, and we have one sitting here on island practicing that has got all the credentials and everything else, they don't have to advertise for me or them or anybody else. They don't have to advertise at all for any local physician who practices standard care equivalent to or greater than in the States. Only off-island hires. Next slide, please. So this was a legal opinion. I paid out of my own pocket, and you're welcome to have it if you want it, and it explains that opinion. Next slide, please. But I want you to, I'm sorry, go back one more. There's one more point here I missed. If you read this, because of that attorney felt that it's a violation of the Organic Act of Guam and the U.S. Constitution and a violation of the Equal Employment Act by not also advertising for these positions at GMH available that they're filling for local physicians. For example, the current surgery contract that is now in place, there was no competitive bidding for that. It was handed out, chinchilli, okay? And could it have been bidded out and procured? Could it have been a cheap, maybe a lesser amount with the same quality of care here in Guam? Yes, there's several very highly qualified general surgeons here in Guam that could fulfill that position too. But was it offered? Was it advertised? No, it wasn't. Next slide. And here's the appointment signed by Peter John about this is an advertisement for off-island physicians. Never has there been one for on-island. Next slide, please. GMH Board of Trustees, you all appointed them, they got approved, can be a factor that reinforces the sole dictatorship of GMH by a single hospital administrator, be it the governor or his proxy or appointed people. Next slide. The governor can be acting as BOT, the governor's appointed proxy, the governor's appointed members, and these members of the Board of Trustees can be inexperienced and not understanding the whole breadth and depth of the needs of the hospital. Next slide, please. Appointed a GMH Board of Trustee that is also a GMH administrator. That's been done before. Next slide, please. GMH Board of Trustees can also be manipulated if they are overwhelmed with work, inexperienced, or seek financial gain personally or for a friend. Next slide, please. GMH BOT approved policy ALD 7000, which specifically excluded physician service contracts from any procurement law, okay? And I discussed this with some of the Board of Trustees members. They didn't even know there was a procurement law. They had just gotten started on the Board of Trustees, and this was plopped in front of them, and they had a whole bunch of stuff to catch up on. Privileges, everything else, and so this thing just was slid in there, and of course, they all voted yes for it, without knowing the consequences of that. Next slide. So, obscured finances. Next slide. This I got off the website. You all can do that. And I'd like to know that far bottom right one, you can't see it, but it tells you the full amount of money collected by GMH with that date there. Okay? How much, I asked this question, next slide. How much of the previous listed collections from last month or whatever that was, March or whatever, no, I think it was April, are from physician service contracts? For example, I do surgery on somebody. Let's say I'm working at GMH as a surgeon. I operate on somebody. There's a professional fee that's billed out. That professional fee bills out to any insurance company, and I get a certain amount of that. The hospital gets the lion's share, obviously, but I get some. Now, I'm an employee at GMH. As an employee at GMH, I should not be getting that. Okay? But they are. So, okay, let's say I'm just on call, on duty. I have to be there 24/7, get up and go and save somebody's life, or she does, or any other physician. I go in, I operate, I collect the services for that procedure. But at the same time, the hospital is paying me to be on call or on duty. That's one part. The second part is a physician that's absolutely 100% employed by the hospital, like an anesthesiologist, okay, ER doctor. They all get 1099 forms now. They don't get any other stuff they used to. And they cannot bill out, they cannot keep that. The hospital owns their revenues. So if the ER doctor sees somebody, put somebody in a cast, the professional component of that should be going to the hospital. Now, the situation that's currently in place with the neurosurgeon and general surgeons and possibly others, I'm not sure because I don't have that information. They are on call. They get paid to be available 24/7 to save life and limb. And if the patient has insurance, they bill out for their professional component for their insurance rather than the hospital owning that. Why? The argument is that the doctors say, well, we won't cover if you don't let us do that. Well, then fine, just advertise and get some that will. And there would be many. Okay, next slide, please. So I want to know, have you ever been told how much money the hospital has earned from their employed physicians? Does anybody know? How much money has the hospital collected from our anesthesia department physicians for doing anesthesia 7 days a week, 365 days a year? How much money has the hospital collected from the emergency room staff physicians 24/7, 365 days a year for their professional component? Obscure finances. Is GMH currently losing money with their physician service contracts? From a hand surgery standpoint, absolutely. I'm sure that because I know what it costs to run a private practice, even with the lowest possible overhead and efficiency. I know what the insurance companies pay me. I don't see indigent, I see indigent patients with Medicaid MIP, but I am not compelled to see patients with no insurance at all, which GMH is compelled to see and always needs to have some funding to help them out with that. Okay? So, and I got a feeling if you're audited and you say, my goodness, wow, we're paying this physician $385,000, but he only generated $100,000 of revenue. Next slide, please. Why were physicians previously listed on the GMH staffing pattern as being paid an annual salary, but were not paid a salary and are now currently not listed? So I brought this up to the Board of Trustees, and I believe that that's the main reason why it's not listed anymore, because for years and years and years, I was always wondering, why is my name listed? Lieutenant Governor Mike Cruz also said the same thing to me. We discussed that together. And some other surgeons. Names are listed, and it's got a salary there. And you go there and look at it, and it says Dr. Lanstrom, Dr. Mike Cruz, Dr. Sabio, $120,000 a year. What is that? Why was that? Where is that money? And certainly we weren't on call, we were on duty, we didn't get paid a cent for that. Why is that? I don't know. Then you got listed on there cardiothoracic surgery and the entire cardiac team. You all know that the Loma Linda healthcare system came out here and said that this island's still not large enough to support that. If you go in there and look, you'll still see the cardiothoracic team listed millions of dollars, millions, just for them. But I'd like you to go there and look at the physicians and then add it up. Now, we all know that it was a money-losing proposition to bring an open heart team to Guam. It's more cost-effective to stabilize them with interventional angiography and treatment, catheterizations and things like that, which are being done on Guam, stabilize them, and then send them to the Philippines or somewhere else. Next slide, please. Why did GMH previously list non-employed local physicians and not being paid? I already stated that. Next slide, please. Why did GMH previously list off-island physicians' annual pay when they aren't even employed at GMH? And they're not even here. Next slide, please. Why did GMH terminate physicians or allied health service contracts? What's an allied health, for example? A podiatrist, a respiratory therapist. I'm not sure about that one, but for sure a podiatrist. Contract to remove a physician or allied health provider that are competent, maintain a standard of care so that a single physician provider can assume all responsibilities previously divided among several providers. Example, podiatry. You have 4 qualified podiatrists to cover the foot problems at the hospital 24/7. That was terminated and given to 1. Was there a discussion about that? Was there a procurement about that? Did it take it out and advertise it? No. Chinchilli. Next, please. Why does GMH not make public their physician and allied health service contracts? Have you seen these contracts? No, you haven't. Next slide, please. Why does GMH administration have a full-time employed hand surgeon when you have the same thing in the civilian sector? Why do they need that? I was told by the BOT and the previous administration, Peter John behind me, I believe it was, I forget, back around the time I was deployed, we don't need, or when I came back, I don't remember, it's kind of a blur, that period of time in my life. We don't need that. Dr. Stadler is the medical director. He said, we're going to cancel the hand call schedule. Finish it. Done. Well, I've been on that schedule for years for 0 payment. Now, for some reason, the hospital feels that they need a full-time hand surgeon to fulfill the same role I provided for years without cost to them. And I don't want to do that anymore. Next slide, please. What financial analysis has GMH administration done to determine what physician service contracts are essential for the only civilian public sector hospital on Guam? Have you seen that? No. Next. Why does GMH have the current physician staffing pattern when GMH is not a level 1, 2, 3 accredited trauma hospital? By the way, there's no accredited trauma hospital on Guam, even Navy hospital. To educate you, next slide. Level 1 trauma hospital you cannot be a level 1 trauma hospital without a neurosurgeon. They may or may not have a full-time microsurgeon that does reimplantations like I do, or have it available. Next slide, please. Level 2 is a step down. Okay, next slide. Is that 3? Yeah, next slide, it says 3. Is basically what GMH is performing as, but no hospital in Guam has been certified as any trauma center. But I can tell you, GMH sometimes goes to level 1, but most of the time it's level 3 because they have retained the services of a neurosurgeon, which is good for the community, and hopefully that continues. Next slide, please. In level 4, you don't have anybody hardly at all. Okay, next slide. In level 5, it's basically, just maybe the very lowest. A nurse can manage those healthcare facilities. Next slide. So at the end of I'm finishing up now. You can go to the Guam Daily Post. Next slide. And you can go to TED Talks. Next slide. And the established carefree attitude of spending someone else's money. My wife loves spending my money, okay? Is highlighted by GMH awarding millions of dollars annually for physician service contracts behind closed doors, but no longer behind smoke-filled rooms because it's a smoke-free facility, thank goodness. Next slide, please. These contracts apparently are based on chinchilla politics and personal bias while bypassing Department administration contract law by creating their own policy outside the oversight of the government of Guam and GMH Human Resource Department. This next slide. So stay right there, please. This legislative body can change that by changing the law. You don't have, okay, so you got a board of trustees that says, we're going to mandate that the hospital administrator advertises to local physicians and wherever they need for these physicians, and we're going to issue these contracts based upon the needs. But the board of trustees changes. Who knows, the next governor can put in whoever he wants there, and then you're back to the same system. So only way to change that, honorable senators, is to go back to the Guam Code annotated, try to, first of all, read it and understand it. I had to read it 10 times before I realized what it was trying to say. But you go there, and you just can make sure that GMH is included in that. The argument might be made, well, gosh, what if they challenge the bid? Patients are going to come in, they're going to die. No, that's not going to happen. GMH has already under administrative and medical staff bylaws, and the medical director can ask and get coverage instantaneously, and they can do it. They've done it in the past. They can do it again. So while somebody's maybe arguing the contract, challenging a contract was awarded to X when Y wanted it, that's not an issue. You can also have what's called bridge contracts. Federal government, the rest of Guam does that. So that argument does not hold up. Lastly, I would like to say this island has shown immense compassion and care for all of its people that live here by funding GMH, by providing health care to those that previously would not have it. And I've noticed it improve over the years, but we still have a long way to go. And I support first figuring out and fixing the issues with finance at GMH. Therefore, I support the bill here that is listed, bill number 262-34034. And lastly, but not, I also support working family relief. Thank you very much, and again, appreciate it to be here.
Thank you, Doc. I'll ask my colleagues. Speaker Cruz, do you have any questions? Senator Rodriguez, I know you have a statement you want to bring up, want to make.
Thank you very much, Mr. Chairman. I want to thank Dr. Lanstrom and Dr. Shimabukuro for your courage this afternoon. I want to apologize to you as well, because about 5 months ago, I introduced a resolution to uncover the corruption that you've brought up this afternoon. However, only 4 senators voted to pass that resolution. And so that resolution is still pending. And it addresses all of the points that you brought up, Dr. Lanstrom and Dr. Shimabukuro. And so, again, I want to thank you for your courage today, and know that we're going to be here to follow up and ensure that these allegations that you've presented are reviewed and that we move forward. Thank you very much.
Senator, thank you. And I just want to say it's not an issue of corruption. It's an issue of institutionalized systems problem, and it cannot be put on one person's shoulder, but the system itself, and you, the senators here are the ones, and the governor of Guam can change that system. Otherwise, we're just going to continue limping along. Thank you very much.
Senator Uggan, do you have any questions, sir?
Thank you very much, Mr. Chairman. I too, Dr. Lanstrom and Dr. Kousouli, want to thank you both personally for making your testimony, presenting your testimony this evening. Some very hard-hitting statements that have originated from the two of you. And Dr. Lanstrom, having worked at GMH since 1990, certainly speaks volumes in terms of the institutional knowledge and experience that you have working at GMH. And Dr. Kousouli, if I can refer to you to your first name, you know, in this particular case, having come into the system just very recently within the last year, certainly speaks volumes about the love and care that you share for the children that you repeatedly stated in your testimony. So I want to thank you both for your testimony, and I certainly look forward to any investigation or research that is necessary to either validate some of the concerns that you have raised. Dr. Lanstrom, you highlighted that it's a systemic issue, and you also pinpointed specific areas as it deals directly with particular physician contracts that perhaps would not be applicable in Guam. So that's where we rely heavily on the administration and on the experts being able to provide that information. In our case, we look at what are the needs of the hospital so that they can provide the best quality, safe care for our people. That's where, at least from my perspective, at this vantage point, we want that assurance, knowing full well that we have the right people in the right places to be able to administer GMH. And because of some of the concerns that you have brought up, certainly it requires some additional investigative work, and I certainly look forward to some of those activities taking place. Thank you very much.
Senator Nelson, do you have anything, or no? Senator Nicholas, sponsor of the bill.
Thank you, Mr. Chairman, and I appreciate the testimony of these two fine doctors for coming before us and sharing with us some of the issues that are affecting our hospital. I also wanted to acknowledge Senator Rodriguez. I agree that in light of this testimony, the need for an investigation has become very, very evident. I think it's self-evident at this point. Perhaps we can fine-tune the language on how that investigation will be conducted via the legislature, but it's definitely something that needs to be, I think, needs to be done at this point. I did have some questions, Mr. Chairman. Now, the bill is specific to repealing the sales tax, and the reason why your testimony is so relevant is because half of that sales tax is supposed to go to GMH. And the case that we've heard on multiple occasions from the GMH administration has been that that is the only thing that we need to do to be able to solve GMH's issues. But you've brought up multiple internal issues that speak to the losses that the hospital is suffering. And if those issues are addressed, then we would not necessarily need to have a tax increase specific for GMH or figure out a subsidy, but definitely not something that's as high as what's needed right now. I wanted to kind of recap some of those particular cost items. The first, Dr. Kousouli, that you spoke to was the medical billings. Now, you had a slide here that you provided to us that showed $22 million in outstanding billings. Is that correct?
Yes, sir. That's a cross-sectional, at any given time, just one day of what was the delinquent medical chart was. That one that was provided to you was a few years ago because that's the only thing that was available at the medical record, and when I was discussing it with the appropriate medical managers and record managers. But it's substantial. It's the amount is $22 million. And then since my arrival and then working with Mr. Byrne and Mr. Clement, we have decreased that. However, that needs to be really looked at, that's for sure.
So this billings number, is that the same as what they go around saying is uncollectible, or is that something different? Is that something that's supposed to be billed but hasn't even been sent out?
It's the bill that hasn't been sent out. It's different from what they're saying when it's uncollectible. This is the total of what you could bill.
So this is money that hasn't even been pursued.
Exactly right. And then just to point it out that the time is money when it comes to medical record. Insurance company denies any claims after certain times, 90 days, and for Medicaid it's 1 year. And that's why this delinquent chart, aged chart equals lost revenues. In the States, we never let that happen, never. To the point that we hold the physicians accountable and then suspend their privileges until they complete it within a few days. That is not happening at GMH.
And this is a current problem.
It is still a current problem because, again, like I said in the testimony, it becomes very hostile quickly when you ask to complete the charts and whatnot. So we started tracking this process of who has a delinquent chart, and it is improving, but borrowing the medical records manager and staff name, the support is not there for them to function more appropriately. There's no clear system. As you can see that we have this policy to suspend the physicians after 30 days or whatnot, but somebody just writes them off and it's like, okay, we'll grant you another 30 days and another 30 days. And that's lost revenue. That's loss of accountability.
Are you aware of attempts to suspend physicians for not doing their billings on a timely basis?
The medical records, you mean? Yes. Actually, we started writing those letters, and then the medical staff, chief of medical staff, the president of the staff is starting to do that. That's a recent phenomenon. Didn't happen before.
Those issues are not written into the contracts, Dr. Kousouli, that they should complete their medical billings within 30 days?
It was not previously, and then still existing contract that I did not execute, it does not state it. The contract previously offered by physician contract, that is, at GMH, is very variable. Some is just like one paragraph, you've probably seen it. Like, you're hired to do this, that's it. No job descriptions, no hours, no mandatory qualifications and a mandatory anything. And so I've never seen that before either. So one of the first thing I've done was to create a template for PSA, Physician Service Agreement. In it, in details, it says if you do not comply with the GMH rules and regs and then document and compliance rules, then you will be sanctioned. That is in the template that I created. But again, I can say that not because I don't even know what physician contracts are being offered. I don't even know. Even though I sat in the executive office, it just shows up. So some of the physicians are being offered without PSA, for sure, like the one I created.
Dr. Lanstrom, on the issue of medical billings, has this been a legacy problem at GMH, or is this just a recent phenomenon?
Chronic, and the contract that is held now to cover general surgery at the hospital is an essential medical specialty. The person that was awarded that contract was the worst offender of not completing medical records. You can go back if the files are still there and haven't disappeared, and you can review and ask for all medical records billings that were not possible because physicians weren't completing the medical records in a timely fashion, and therefore the hospital could not bill out for it. I would go bankrupt if I did not do my OR report in a timely manner. When I operate on somebody, I have to get it done, submit it to the insurance company, or that's it. Same thing with any patient I see in my clinic. And for whatever reason, it has not been addressed over the years. And I have seen one of the contracts issued to the physicians. There is absolutely nothing in there that says this contract requires you to do your medical records on a timely basis so the hospital can bill out and collect the revenues of your professional component as well as the facility fee. The facility fee is the lion's share of that. Okay? The daily rate, the OR time, ICU, emergency room, it's a huge number, like I said. The physician's portion is very slim, but if that physician doesn't dictate that out, get the OR report there, or do the H&P or whatever, they can't submit it.
With respect to these billings, I'm alarmed to find out that the hospital doesn't keep 100% of what it bills. Is that across the board, or is it just under certain circumstances, under certain special contracts? Dr. Kousouli?
Your question is that the hospital is not keeping the bills, and the bills of the physician fee, you're correct. We only keep certain contracts. That ones I know about, which you mentioned, and then which I oversaw the executions of, was anesthesia department's contract. All the GMH official contract that's offered to the existing GMH anesthesia physician, I made sure that GMH keep professional fee and also every other fee that's associated with the care we provide. And that's the normal way of offering contract. And that's how the hospital makes revenues. However, I know of some contract that doesn't do that. And this is even despite being on-call fee or salary. Anesthesia physicians are salaried, and a few others are. And then that some physicians are being paid salaried and are also keeping their physician's fee also. I am aware of that kind of contract exists. So Mr. Ed Byrne and I was working on the estimating of those loss of revenues because of the hemorrhage of the physician billings, and then he verbally told me it could be up to $9 million. That he told me verbally, so I cannot provide you the documents, but he estimated that, and he was very concerned about it.
So based on your PowerPoint, we could have upwards of, at any given time, up to as much as 22 million in billings that are not being billed. That's revenue that could have come to the hospital. And on top of that, we have an estimated as much as $9 million loss because of a percentage of billings being retained by the physicians who are also receiving a day rate or a salary from the hospital as well.
Yes, just with those two items. And then I've discovered more, and I don't know how much time you have, but yeah, there are a lot more that we can do better. For example, I mentioned the utilization review committee. They're so understaffed, and then that, GMH hires other staff like admin assistants to this section and that section, but they don't put money into the right place, like utilization review and billing and collection. Any private hospital, any hospital would say, forget about having another secretary, hire another UR person or hire another billing and collections person, correct? They don't have enough utilization review staff, and they're not doing any concurrent review of the current chart. What that means is that insurance company, they have a concurrent review person that's coming every single day to our facilities and reviewing the chart. And 1 minute, the doctor documents something, says, oh, the patient's getting better, or, like specific language they have monitors for, and they say, oh, this patient does not qualify to be in the hospital. Then from that day on, your hospitalization reimbursement's denied. We call that aberrant days. If you have a concurrent review team, you would look at that and catch it, and you say, hey, doc, can you change this language and say this person is required still hospitalization because of this reasons? This happens daily. I get a phone call from people all the time, clinical documentation specialists, or whatever you want to call it. At GMH, this is not happening. And then when they try, the UR staff try to call the medical staff physicians, they get yelled at and they say, you're not a physician, you're not an expert, what are you telling me about this? And then they were being absolutely abused. They can tell you that in person. And in the new utilization review policies, including 2 midnight rules, I included it that when there is a discrepancy in the UR managers and the physician, and there is a strife between the person who steps in and talks to the physician should be a physician, either UR manager, UR committee chairperson, or the medical director. And then since my arrival, I've been doing that. I've been taking that role and I say, hey, the internal medicine hospitalist doesn't want to downgrade from ICU to the acute care, even though the patient is not ICU criteria. Surgeons doesn't want to downgrade and this and that. I step in and I call. I take the bullet. And as a result of that, this unnecessary denial could be decreased. But that's not happening. That's another revenue loss for sure.
And Mr. Chairman, I'd like to also enter this into the record just to be attached to the committee report, the Pacific Island Times article, TED Talks, where they interviewed the former GMH administrator, Ted Lewis, and just focusing in on what he mentioned as physician double dipping. So what he's talking about in this article, that's the practice of paying a physician both a salary and allowing them to retain a percentage of the billing? Dr. Lanstrom?
Not a percentage. Well, the total amount, yeah. They get 100% of their physician fee. So this billing has to do with a big pie, and out of that one slice comes the physician services. So and they get 100% of that. So whatever, for example, all right, somebody does a laparoscopic cholecystectomy, the hospital gets paid maybe $5,000 for 30 to 60-minute procedure, and a surgeon gets $1,200. Okay, so it varies upon depending on the CPT code, Common Procedural Terminology, which I have to put in every one of my notes and reports. So there's another issue too. If the hospital's not putting in the right diagnosis code and the right CPT codes, it's going to be rejected by Medicare, MIP, Medicaid, and the private insurance companies, and they're going to then send it back, and sometimes it just gets lost in the shuffle, and guess what? It's a stale account, 45 days have gone by. Oh, we don't have to pay you, but thank goodness CMS is a year.
So what happens to the physician fee? If it would have been paid by the insurance company, but it got lost in the system, or didn't get processed fast enough, does the hospital have to pay the physician fee?
No. For example, health insurance X is billed out $7,000. Out of that $7,000, so that's what the hospital gets. But the physician or surgeon providing that surgical procedure, the physician component, that person bills out $1,500, let's say. The hospital's billed out for the facility for $7,000. The physician bills out his, and he gives us a report in. Let's say the physician then forgets to or doesn't fulfill the medical records like she pointed out, but he is sure to, or her are sure to take their OR report and submit it. And it's because it's out of their private practice, they will get paid. But then the hospital's bill is sitting over here because maybe they haven't signed an order, maybe they haven't dated an order, maybe they didn't sign date and time an order, And so it's an incomplete chart. Maybe they didn't enter the date they saw the patient postoperatively, okay? And they have to write that note. Maybe they forgot to put the OR report into the chart, so the physician gets paid, but the hospital doesn't.
So the physician fee is sent in separately from the hospital billing?
Yes, it's sent in separately. But yes, it's sent in separately. And in the past, that this program has been terminated in the past because there is such a high uninsured population. The physicians were allowed to bill out the hospital. They weren't getting paid to be on house call. They weren't getting paid with contracts. They just said, Dr. Landstrom's on call, he comes in and he can bill the hospital. And the hospital would sometimes pay the physician their professional fee if they had money.
So in some previous records that I've seen, GMH gets paid about 70% from the insurance companies. Does that mean that the physician fees are only getting, the physicians are only getting 70% of their physician fees also? Or is it likely that they're probably getting 95% of their physician fees, but the hospital's still only getting 70% of the actual?
It depends on the contract that the physician has with each insurance company. And there is a copayment and deductible. And those are the private companies. It's a little bit different with the Medicare and Medicaid and MIP.
And so, I'm sorry, Dr. Lanstrom, I don't mean to interrupt you, but so a physician at GMH gets paid by GMH on a daily basis to be on call or to be there when they have to be, and they're getting to keep or they're getting to bill for an additional physician fee for providing a service at GMH. So GMH calls you in and says, I need hand surgery for patient X. You get your on-call daily charge, plus you also get a physician fee?
That's the way it's currently arranged for podiatry and surgery and neurosurgery. I cannot speak of hand surgery by the employee, but I don't think that person can do that because he was hired as a full-time surgeon. So hopefully that's not the case where he's also collecting the physician service fee. I don't think so. But yes, the answer is yes for those that aren't full-time sitting in the hospital, running a clinic out of the hospital. Yes, the ER doctors see a patient, they don't collect any of that stuff. Anesthesiologists, they don't collect any of that stuff.
So, and then this ties back though to that case she made about the contracts, about how a single person can write out almost any kind of contract, doesn't need to announce that contract if it's for a local hire, and that locally hired physician can work at GMH, get paid on a daily basis, $1,000 a day, and when they perform a service at GMH using GMH resources, GMH nurses, GMH supplies, they're collecting a physician fee for providing that service to GMH.
Physician component, that is correct. Everything you said is correct.
But that's only for some doctors, not for all doctors.
That's only for some doctors and not all doctors, because you have those that are under 1099s and they don't bill out for any of that.
Yeah. I'm hoping my last question, Mr. Chairman, is Dr. Kousouli, you mentioned transfusions. We passed a law allowing us to bill for transfusions, but we weren't billing for transfusions until just recently.
They were billing it, but it was getting flat out denied by the insurance companies, even though the law that Senator Rodriguez had it passed mandates them to pay us. And then I think the atrocious part is that nobody knew it was getting denied, that this hemorrhage of the revenue was happening until I got there. And to the point for several months I kept bringing this up, and then they said, no, don't worry about it, we're getting paid. And I had to really produce on the document saying, no, it is not getting paid, we need to go after this. So transfusions happens all the time. We lose so much money. every single day, every time we give transfusion. And we're not going to stop giving the transfusion because it's life-saving measure. But least we can do is that if we are government hospital that's repeatedly being subsidized by the public, then let's do our best to capture the revenue. That's responsibilities.
Are there any other examples of insurance billings that were not taking place that you determined, because those are also revenues that the hospital is not receiving?
Sure, there's tons of examples, but to break it down and just make it easy, everybody gets a glucose test, correct? Just blood sugar test. If we check these glucose on diabetic patients, like 20, sometimes on some patients, and like the patients who's unstable, we check it like once an hour. The glucose test costs about $30 plus per test. Because of the exact reason Dr. Lanstrom just said, not having the correct code for that diagnostic code for the patients, and not having the documentations in the medical record of the reason why we are ordering these glucose tests, these were getting flat out denied. That's like $40,000 every few months. And this has been happening for how many years? Nobody could tell me, but since I'm the only person who's looking into it, I bet you this has been going on forever. That's ridiculous. And the reason why that glucose section, by the way, glucose comes in a panel of labs called Chem7. Chem7 has a OBMP, basic metabolic panel. It comes with the wonderful things like electrolytes, sodium, potassium, chloride, bicarb, BUN, and creatinine. Then there's glucose. There's wonderful 7 that comes with it. We used to be able to bill out to the insurance companies and CMS and whatnot, the Medicaid and whatnot, as a Chem7 or BMP. But a long time ago, years ago, they changed that. This panel doesn't need to be together. They took out the glucose. So you know what we did in US? We made a different panel. There's electrolytes panel, and if you want to order glucose, you have to order it as I want it as a physician. Electrolytes panel together with glucose. So that way, physicians are thinking, oh yeah, I need the other orders, and then there's a reason behind that because my patient's in ICU and then the patient's not eating for 24 hours. I want to know the blood glucose. So we will document it in the orders and in documentations. That's how we capture revenue. It was not done. Same thing, there's several things that's been missed like that, like coagulation panels. Coagulation panels are PT, PTT, and INRs, which checks for how likely are you to bleed, or if you're on warfarin or Coumadin or some. Those panels been changed, so you cannot build together. And that change has been there for years also. Has GMH updated their panels and ordering system? They have not. They absolutely have not. Easy fixes, isn't it? Easy.
Mr. Chairman, it's very clear just in the testimony that's been provided today that, aside from the fact that when the GMH administration was here 2 hearings ago, they testified that Dr. Kousouli was not in the capacity that she was in, nor was there ever anybody. And that has been refuted with documentation that was provided on the slides. On top of that, we've been provided with information that clearly indicates as much as $31 million in billings and contracts that could be revisited, as well as insurance billings and insurance charges that could clearly be revisited. I think that the GMH administration needs to spend less time in public hearings and more time addressing these issues. So, Mr. Chairman, with that, I'd like to thank these 2 doctors for coming forward and providing the testimony that they did. That is a very brave thing to do. And in light of the other facts that was shared with respect to what's happened over the past several months, Dr. Kousouli. I want to thank you personally and on behalf of the members of the legislature for your service to this island and to this community. And I think that your daughter will grow up to be very proud of her mom. Dr. Lanstrom, thank you as well, sir. I know that you have a private practice. You're not even doing business at GMH anymore, but you're here testifying to provide us with additional information based on your legacy experience having worked up at the institution. So I wanted to express my thanks to you as well, Dr. Lanstrom, for putting together a PowerPoint and being present here this evening. Thank you, Mr. Chairman.
Thank you, Senator Snickers. Thank you, doctors. Your testimony will be provided to Senator Rodriguez to his oversight committee on GMH, which will be conducting their hearing next week. The committee will conclude the public hearing on Bill 264 and 262. The committee will continue to receive testimony for the next few days by June 14th. Please address your written testimony to the Committee on Education, Finance, Taxation, and submit it via email to Senator Joe S. San Agustin at gmail.com. My office is located at Rand Care Building, second floor, Suite 3, 761 South Marine Corps Drive, Tumuling, Guam. Si Zeus Marcy for your attendance and participating in today's hearing. And for those at home, thank you for watching. It is now 6:38. Good evening.
Ben Prebetso.